Thanks.
Sure. Right.
Thanks, Dave.
You got it.
Are you gonna make that?
My name is Fred Palmer, and I was diagnosed with non-small cell lung cancer in October 2013. I'm currently undergoing immunotherapy.
Thanks, Fred.
My name's Robert. I was diagnosed with stage 4 non-small cell in May of 2014. I normally don't talk I don't know, whatever, but I would like to give a shout out tonight for my caregiver, my wife Joanne, back there,
There she
daughter
is.
Lisa, my son-in-law Jamie. I've been doing fairly well. Have some scan and tests coming up in the next couple of days, and hopefully everything will be good.
Awesome.
I also want to express my appreciation for Lonnie and the foundation, Michelle. It's been a lot of support, and I'm looking forward to the walk next month.
Thank you. Is that mic working? It didn't sound
It
like
wasn't.
I think they're working on it back there.
Okay.
Hi, I was diagnosed with stage 4 non-small cell carcinoma back in February 2015. I went through 12 months of chemo. I didn't have any of the mutations or anything to get the fun stuff, so I got straight chemo. Did a year of that, but I've been, all my scans have been clean for 18 months now. So things are good.
On chemo.
On chemo.
Clean scans.
Straight chemo.
Wow.
So,
Awesome. See? Great. Rick, you're not going to say anything?
I'm Rick, and I'm Tina's husband, the beautiful woman sitting next to me. And she'll tell you all about her story.
I'm Tina, and I was diagnosed in 2010 with the EGFR positive, so that was a good thing about my diagnosis, the only good thing. But I did do chemo and radiation, and then I went clean scans after that, and then I went on Tarceva for, I don't know, I guess for insurance maintenance. And I've been on it ever since, and it's been 6 years on Tarceva. So those of you that are starting on Tarceva, it does work for some people.
Thanks, Tina.
I'm Homei. This is my first time to join the living room. It's a wonderful place. I have been a scientist on cancer research for about 20 years until I was diagnosed into LP. Actually diagnosed with breast cancer. I went to volunteer in Bay Area Cancer Connection. For some for a few months until I ran into Abby. I probably many of you know Abby and Abby. And then because there are breast cancer patients have metastases, like cancer can metastasize into lung. So in the breast cancer community, there are also people running into the problems with lung metastases. So that's the reason we start chatting. And then I heard a lot about the wonderful work from Lung Cancer Foundation, like the research program and also clinical trials and also patient supporting program. So that led me to meet Tony. And Tony told me about like a lot of more like wonderful work you have done. So because I'm a scientist, and especially after me being diagnosed with cancer, and I have a whole new view about cancer, being a patient and being a research on cancer. So I come here to say how much more I can use my knowledge and experience to help the community. So that's the reason I come here. And I want to serve the community, the cancer community as a whole, to use my knowledge better. Yeah.
Thank you.
Thank you.
Joanne.
My name's Ron. I'm the husband of the patient, and the patient here is Joanne.
Yes, I'm Joanne Berridge, and I am EGFR, diagnosed at stage 4 after a year of misdiagnoses, and I always make a point of repeating that every month because any provider anywhere that's hearing that I should not have coughed for a year and been diagnosed with allergies that didn't exist, post-nasal drip, and what was the other one? Acid reflux. And then finally, a year later, a chest x-ray and I had a 5-centimeter tumor, and it had metastasized to adrenal gland and bones. However, the good news is my response to Tarceva was extraordinary, and the tumor went down to, well, at the last scan, it was no more than a centimeter. And the bones were clear and the adrenal gland was clear. So I am coming up a year in a couple of weeks of having been on Tarceva, and am very grateful to Genentech and all the scientists and researchers involved, not only in the targeted drugs, but also in identifying the genetic mutations that then allowed for the drugs to be developed. And I am also grateful to my dermatologist because I'm a rasher. It comes and goes. I can go for weeks with no rash, and all of a sudden I'll wake up one morning and it's just all over the place. But the ointment is great, and I think that's it for me.
Thanks, Joanne.
My goal is to follow Tina at least 5 years.
Yeah, everybody's following Tina. That in the back.
Go ahead, Stephen. Just say hello, who you are. Yeah, I'm going to try to catch everybody in the room who's willing to talk. I'm going to get to the back row next.
Hi, I'm Stephen Young. I have the honor of serving as president of the Addario Lung Cancer Medical Institute, this sister foundation, the other foundation that Bonnie and everybody founded. And we're a global research consortium focused on patient-centric research. And I'll leave it at that for now, unless there are questions.
Thanks, Stephen.
Hi, I'm Barbara Gitlitz. I'm a medical oncologist, and I recently left University of Southern California to come work at Genentech and work on the immunotherapy treatment for lung cancer, and a good friend of Bonnie.
Just Bonnie? That's whatever, Barbara. I'm teasing.
It's all about Bonnie.
And Dr. Gitlitz was the principal investigator, or the lead physician behind the Genomics of Young Lung Cancer study. And just as she walked in here, we had just described her. She should be getting a sainthood for what she did for that study, and in partnership with the patient. So great to have you, Barbara.
Hi, I'm Deborah Morosini. I'm also an old friend of the Addarios. My sister was Dana Reeve, who died of lung cancer, and that's how I came to the lung cancer world, and I've been working with this crew for many years. And I'm a physician, and I am with a company called Loxo Oncology. We have a therapy that does work for lung cancer patients if they have an NTRK fusion. So that's a new slice of the lung cancer pie. And before this, I was at Foundation Medicine, and I was really proud to be a part of Genomics of Young Lung when I was there.
Thanks, Deborah. Robert already introduced them. I don't know if they want to talk, but maybe back here. Thanks, Bridget.
I'm Ken Lee Chin, and my mom was diagnosed early this year with a stage 4 adenocarcinoma with EGFR. So.
Okay. I have a stage 4 since April. So far, so good. Not much reaction, so I'm very happy.
Thank you.
My name is Beth Zaharoff. I work for Tesaro, which is a smallish oncology-focused biopharma company in Massachusetts. And my role at that company is patient-focused drug development. So ensuring that the work that we do is relevant to the people who we're hoping to serve who are enrolled in our clinical trials and to try to eliminate as many burdens as we can.
Hi, I'm Cheryl Lapidus. I'm with the Corporate Affairs Department at Tesaro, and my responsibility is to help support the patient advocacy organizations as well as professional medical organizations in oncology.
My name is Amy Dolnick, and I am with Tesaro. I'm the key customer liaison, so basically the connector of the company. And 6 years ago, I had the pleasure of meeting Bonnie and Tony Addario at a conference, and as everybody knows, and her family, they're infectious, and you just can't stay away from them. So thank you for what you do for patients every day.
Hi, good evening. I'm Doris, and I was diagnosed in August of 2015, so it's been 2 years now. Adenocarcinoma on Tarceva, and doing very well. My last scan had no activity, and so hopefully it will continue on. And I found the Addario Foundation right off the bat with the help of my oncologist and as well as my social worker and my family, and came right away and learned so much from the living room. So I'm very grateful.
Thanks, Doris.
And this is Maynard, my caregiver.
That's it.
Your silent caregiver.
Michelle, is there anybody online that wants to say hi or introduce themselves, or I'll just be
Very quiet. A lot of people.
A lot of people very quiet? Okay. Well, hello to everyone online. Please feel free to chime in. As you guys know, this is open forum, so please feel free to ask questions throughout. What we always laugh about is everybody tends to be really quiet up front, and then when there's like 15 minutes left in the program, everybody has a question and something to say. So you don't need to hold your questions till the end. Sometimes patients say, well, I feel like my question might be selfish because it's centered only towards me. It's probably not centered only towards you, and whether it's someone in the room or someone online or someone that's going to go back and watch this, I'm certain it will be relevant and have impact for someone else. So please, please, please don't hesitate to ask your questions. So with that, I thought before we jump right into the Q&A, at the top of my little list here, I pulled what I thought were easy to sort of understand definitions between supportive and palliative care versus hospice care. So I thought that might be a nice way to open up before we jump in to the conversation with Dr. Arena. So palliative care, which is what they call it for the most part, it's not called supportive care other than here when I always put that slash in between to make sure that people understand what it is we're trying to talk about, is to prevent or treat as early as possible the symptoms of a disease side effects caused by treatments and psychological, social, and spiritual problems related to the disease or treatment. So it's really, on some level, symptom management. So you're having these treatments and maybe you're having some side effects, whether it's, we're going to get into some of the side effects later, but nausea, vomiting, rash, bone pain for those who maybe have metastatic disease. And then hospice care is a form of palliative care that focuses on caring but not curing as a person is approaching end of life. So physicians, when they typically, at least what I hear from patients, when they typically talk to a patient, they put palliative care all in one big bucket, and patients tend to automatically assume that means hospice care, but it does not. So, Dr. Arena, from your, are you in it? Okay.
I just want to mention something about hospice. I know a patient that's been in hospice 4 times.
Yeah, and then released.
And continues to graduate from hospice. So, I don't want that to be a scary word.
So technically, and I think we'll get into this a little bit later, but I think hospice care is defined as someone whose life expectancy based on X, Y, and Z is 6 months or less, correct? And palliative care is everything else. So what you're saying is there was sort of this oops.
Yeah.
Yes.
Well, not oops. Yeah. Well, we have an expert here.
Yeah.
So.
Yeah.
Well.
So what are issues that are addressed in supportive palliative care? What are we talking about?
Well, before I even say anything.
Yes, please.
I want to just tip my hat to all these people here in this living room. You're amazing. You're totally amazing. And the first thing I think that people should hear and look. You don't look like cancer patients. Love that. And that's the point. That's the point, you know? The idea that you look good, that I hear stories, 2014, I hear 2015 diagnosed, stage 4. Whoa, that's not supposed to be, right? We're not supposed to have that in lung cancer. Wrong. You are the proof. And for all those that are watching this or will watch this, forget me. You is what they should be looking at. Because you are the embodiment of what the science is. You're here. You're going forward. You're looking good. Having a glass of wine. To me, that's why pharmaceutical companies, that's why researchers, why physicians, why foundations really exist. Not to say, oh my goodness, what are we doing? You are what we're doing, and you represent that. So with that, I give you a clap, because you are the best. Now, I'm not going to be rude, but I'm from Brooklyn. I'm going to say exactly what I mean. See, from New York, we can be rude. We're like that. We're taught with somebody said that sometime. But I think I'm rather precise. I hate the term palliative care. I hate it. I love the idea of supportive care. And I was taught many years ago by some very brilliant people, both at Cornell, New York Hospital, now called New York Presbyterian, at Memorial Sloan Kettering, that the true meaning of being a doctor is to be a physician. And that's a huge concept. A physician takes care not of just the abnormal tests that you get, but takes care of you. I heard you say that, but I won't move so much. But the answer is a physician takes care of the whole patient. I can't get a cancer better and make the patient fail. That's silly. I must support the patient in whatever that must be. The interesting thing is, for decades, people have been doing this. Physicians have been doing this. And rightfully so, the science behind supportive care has grown because the science of medicine has grown, the science of oncology has grown. Hey, listen, when I was a medical student or a fellow at Sloan Kettering, the only thing we had for nausea was Compazine. That was it. There was nothing dynamic about it. And a dear friend of mine, who I was his fellow, a very brilliant oncologist named Dick Gralla, started to say, hey, let's do some studies here on nausea and vomiting. And I said, wow, what are you talking about? We have Compazine. And back in the day, you could tell who was getting high-dose chemotherapy. You know how you knew?
They were thrown up.
Yeah, you could hear them on the end of the hall. And I said, yeah, we got to do some studies here in nausea and vomiting, because this can't stay. And so my answer to you is, I agree fully with the idea of supportive care. But I think it's part of the fabric of being a physician. It's not something, let's get a subspecialty in it. Hey, if a physician's not helping you with your support, get the heck out of there. That's not a physician. We could do that with a robot. My answer to you right now is that we must break down barriers, fill the gap. Yes, science is wonderful. We love science. Science is putting us to places and where we have EGF tumors wanting to cry uncle. We're going to have other tumors crying uncle soon, too. But the answer becomes, I don't like the term palliative care. It has a connotation to me like, oh boy, that's all we can do. That's not the case at all. Palliative care should mean supportive care. And if the word is bothering us, get rid of the word. That's all. Just get rid of the word. And I think that's the truth. You know, 90% of all cancer patients are treated in an office or a clinic, not in a hospital. So usually palliative services are usually in the hospital. But your doctors and your nurse practitioners and your PAs, they should be giving you that supportive care. I don't care what you call it. Call it Helen for all I care. But as long as you get it. And so that's a long-winded sentence for what I really think of this.
So I think it's fantastic. I think there brings up, there's so many sort of barriers to supportive care and things that you said. So the physician should be talking to the patients about it. And if the physicians aren't having that sort of, you know, shared decision-making and that larger conversation, and the patients think, well, I have cancer, treatment's supposed to make me sick, what happens to that patient? Because we hear about that happening all the time. The doc's not telling them, the patient's just assuming that's how they're supposed to feel because they have cancer and they're being treated for it. Then what?
You know, there are so many misconceptions, so many stereotypes, so many things that I think we have to burst and break. Cancer patients don't have to look feeble. They don't have to look frail. That therapy does not mean it's ineffective because a person's not suffering. That we have ways of treating the symptoms of disease and the symptoms of treatment that are amazing, just truly amazing. And that truly is what the patient should hear on their first encounter with any oncologist.
You know, we tell...
I just want to, before you ask I just want to raise of hands for who had that conversation at your first appointment. Anybody in this room?
No.
About symptom management, about we're going to start you on treatment, this is what you can expect, but we can manage it.
What the side effects might be.
Print out, you did see. Okay, go ahead.
That's okay. We always tell patients as soon as they walk in that door that this is not your grandfather's cancer. That we do have drugs now that keep you pain-free, nausea-free, you know, as much as can be done. But that conversation has to happen on the day you're diagnosed.
Well, I think it has to happen on the day you're diagnosed. Well, you know what? The day you're diagnosed is like 9/11, you know? It's a tough day. Tough day. And you think the world has ended, and you realize on 9/12 it didn't end. See? You know you're going to go forward. So there's a lot of things that are discussed on that first day, Bonnie. And a lot of it goes over your head, some goes through the ears, some of it you just don't want to hear. And so it must be a repetitive thing. In our practice, and I'm very proud of it, for over 20 years now, we've had a concept. And the concept is that on the day one that I meet a patient, I will talk to the patient, I will go over everything, what I think, what we can do, where we're going, what are my strategies, how we're going to get there. And then I said, you know what? In the next couple of days, you're going to sit down with my nurse practitioner, and she's going to go over side effects, even though I just did, because most of the time they're not listening. I'm not listening. I'm trying to read into their face. See just where are we now? How scared are they? Because it's scary. And so we have the concept of using our nurse practitioner. We call it a chemotherapy teach, whether it be for true chemotherapy or hormonal manipulation, if it's breast cancer, whatever it might be, oral, intravenous, I don't care how the medicine is given. And so that the patient now has a second opportunity, not just with a reading a handout. Handouts are fine, but we want person-to-person contact.
I did have a teach.
Good. That's exactly what should be. It should be an ongoing dialogue. It should be a reassurance that we're on the same page, that we're not here to torture you. That's got to be. And the good news is that so many things have happened in a short period of time. It's not your grandfather's chemotherapy. It's not your grandfather's cancer. We're just approaching it differently. There's a paper, where doctors like to read papers. We call it papers. But it was in a journal called The Clinics of North America. And back in I guess I was the chief resident about 1978 at Sloan Kettering. And this Clinics of North America came out, I guess, in 72. And it had the listing of diseases, cancers that could be cured, cancers that you couldn't cure but you could control, and those cancers that you couldn't do anything about. It was written from one of the former heads at Sloan Kettering. Well, I got to tell you that the first category, those cancers that could be cured, was really like 1 or 2, if that. And then those that could be controlled, well, maybe it was a quarter of a page. And then those that couldn't have anything to do, that was like 3 pages. By 1978, that article was redone. And now all of a sudden you had a dozen different diseases that could be cured. You now had a page and a half that could be controlled, and you had a very small group that nothing could be done. If that paper was redone now, I have none in that last page. That's amazing. That is incredible. And to me, I think that's the message that probably on your first encounter you got to hear, that this is, like you said, not your grandfather's cancer, not your grandfather's treatment, not your grandfather's anti-nausea medicines. This is totally different.
Zofran.
Zofran, I think, there's different types of nausea and vomiting from chemotherapy. I didn't know that until perhaps 15 years ago, 18 years ago. We all thought, you get sick. And then we realized that there's at least 3 different types. There's anticipatory. You just look at me, I tell patients, they throw up. I mean, that's... And they do. They do. And then there's acute nausea, right? Within 24 hours of getting the treatment. And then there's delayed nausea. That delayed nausea was an understanding that is the most recent of all of it, and which we're trying to do something about. And so for a long time, we started to get really good at acute nausea. Zofran, Kytro, Aloxi, great medicines, hitting on the serotonin pathway, part of the things that we realized. One of the studies that I did way back when with Dr. Growler was on medicine that would eventually be called Emend. Important medicine, but had a lot of problems, still has problems. You take it orally, you got to take it 3 days in a row, you got to watch out what medicines you're on, you could have problems with the heart. These ladies in the back, they're part of a company that's got a new medicine called Verubi. Same family as the Emend, but it's only once that you have to take it, and doesn't mean go against other medicines, so you don't have to worry about how it's going to affect your heart. That is game-changing, because now what you have is the idea, the evolution of science, how we can have science work not just in understanding diseases or therapies, but the side effects and supportive care. This is crucial. And so I really do think that it's an ongoing discussion. Sometimes patients don't want to tell a doctor stuff because they're scared. They're scared that if they say something negative to me or someone like me, that I might do something. I might not give them the therapy that they need. But that's why I lean on my nurses, my nurse practitioners in particular, my PA, because they're sweet. They're not going to do anything bad. They're not from Brooklyn. And they trust me. And I trust them to relay the message. The message is, we're going to get you through this. And supportive care is the fabric of the therapy that we're going to give. It's not an ancillary, it's not an add-on. It's the whole thing.
So we talked a little bit about the different types of nausea, and kudos to Saro and their new drug and all the wonderful things that come along with it for patients. But I think that crosses the board, outside of even nausea, right? We look at pain, and we've had patients say, well, my doctor prescribed X, but that makes me nauseous, so I can't take it. And having the conversation with the patients about there is a lot of times more than one drug for any one symptom.
Thank God. One size does not fit all, and one drug does not fit all pain. Doesn't fit anything, one. And I think, again, we look at pain from different types of standpoints. My youngest son had a kidney stone recently.
Oui.
And he was rolling on the carpet. He couldn't get still. That's pain, that's acute pain. And we brought him into the ER, and he got a shot of morphine and said, hey, Dad, wow. Well, that's good for pain, if it's an acute pain like a kidney stone, a gallbladder pain, a trauma pain, it's probably real good. You have other pains. A cancer pain often is chronic. There's a chronicity to it, right? It's not only with peaks and troughs, but there's this level of pain throughout. You just can't get comfortable. And so we have become very imaginative. We have realized that we can have delivery systems that may not be your typical pill, may not be your typical injection. We can use patches that can deliver on a long-term basis a level of pain relief. But it has to often be augmented. And so, again, science, pharmacology, understanding the basics of the biology of what pain is and how it gets derived. One of the things that I'm certain that as oncologists we're all familiar with now are most of our chemotherapies give neuropathy. Neuropathy is this shooting pain like your feet are on fire, or your hands. And we see it from almost every category of drug. The cisplatinums, the oxaliplatinums, the carboplatinums, the taxanes, the taxols, the abraxanes, the taxoteres. Name it, the vincoalkaloids, the vincristins, the Velbans, name it. Commonplace is neuropathic pain. If you give a patient in that circumstance just a pain pill, it's going to laugh at it. Going to laugh at it. And so as I usually say to patients, in a renal world, it's a strange world, a renal world.
Sorry, you got me as I was taking a sip. I like it.
In a renal world, we use medicines that we use for other things. Things like seizures. Things that for post-herpetic neuralgia. I'd be giving to my patients that have neuropathy, gabapentin, Lyrica. And it will cool the jets of that nerve root that is just fizzling and driving people crazy. So your answer is so intense that we can't do the same things. We have to learn to individualize and target. and what the pain is, what the mechanism of pain, what the mechanism of nausea is, what the mechanism of bony destruction might be, and up our game and really use the appropriate treatment in the appropriate patient.
I couldn't agree with you more. I think that's so important because we have patients all the time saying, no, nothing works, nothing works, nothing works. Well, what have you tried? Well, my doctor gave me this, and then they gave me that, and then that's it. I'm not even going back. It's not even worth it. So I think it's an important point to make. And before, I'm sorry, because I'm going to ask you to tell your patch question or your patch story. Okay. Because there was a time when, I don't remember if it was after your surgery or it had to be because you had chemo radiation first after the surgery and they had you on a fentanyl patch. Tell these beautiful people what you did. That was so stupid.
Well,
only a daughter could say those words.
Yeah, right, exactly. It's one of the things that makes this show so amazing that I get to say stuff like that.
But you know, that's a good segue into a bigger discussion about when does a patient talk to the physician? And I just decided I was on, I think, 50 milligram patch.
50 microgram, yeah?
Yeah. And I just thought I was doing so well, I thought I would just take it off.
She didn't need it anymore.
Didn't bother calling the doctor, asking what was going to happen. My husband found me on the sofa, several hours later, and I was in withdrawal.
Yeah.
Totally in withdrawal. And, my heart goes out to people that have ever experienced that because it's horrible, absolutely horrible. So he's on the phone with my doctor, who was just a love bug, and he's asking him, he's going, well, what's different today than yesterday? And so they get down to,
she can't stop throwing up.
He tells him that I took the patch off, and he said, oh my God, put it back on right
She'll
now.
feel better immediately.
And then we'll start weaning her off, this medication. Then I was terrified. When they finally took off the last patch, I thought, oh my God, what's going to happen? But it was all fine. But don't try to treat yourself. Okay, so that's the message here.
Don't do that.
Let the physicians. So I think it's also important to make a patient feel like that's okay, that they can call someone.
Yeah.
And get that help they need.
This is it sounds basic, doesn't it? Communication.
Yeah. Well,
ain't so basic, guys.
No.
Do not get her
in
started.
In fact, you really. It doesn't. I think this is one of the greatest inventions that happened or changes in medicine. I say that very openly that I wasn't at first a believer, but now I'm totally a believer in the concept of the nurse practitioner, of the physician's assistant, because it just gives this avenues of communication just so much more open. Because things like this, which are, rather rudimentary, that a person said, can I take off the patch? If Bonnie just had to call and got the nurse practitioner, don't do it. And it would have been stopped. And so it doesn't have to necessarily be with the medical oncologist who at times right now is running around like a chicken without its head because we're pushed in so many different directions. We do have people that can really fill in some of the gaps, and they really mean well, and they know if there's beyond their capabilities, hold on a second, let me get him or her on the phone. But they can really save stuff. So I am a total believer. I think this is really in the benefit of a true supportive care. Let's increase the family size.
And to that point, just one more comment about that. I tend to see that adult patients don't value their own care as much as they would value it for their child or their loved one. And I think it's very important that you realize that you are important to someone and you need to take really, really good care of yourself and call that nurse practitioner or physician or whoever you have to call and do for yourself what you would do for someone you love.
So this is I'm going to ask a question, it's actually not about supportive care, but it's based on something you said, and it was that you were not a believer in nurse navigation or nurse practitioner, or can you tell me why and what changed your mind? Because I think it's important, because we push it all the time.
Well, I think it has to do with being, first of all, nurses are most important in the whole litany of medical care. And without getting into politics, they've been getting a real rough go of it. We really need nurses, and that's not because my wife's a nurse, but it's because they truly give a hoot. Huh? They care for you. They're there. They're there if you have an accident or if you're feeling ill and stuff. They're wonderful human beings. The nurse practitioner is, again, another step up. They're giving more education, more experience, more things. And at first, I thought it was some type of flimsy way of the medical establishment or the insurance companies or whoever, the government, whoever it might be, aliens, to sort of water down the level of care. And I was wonderfully, marvelously surprised. Because instead, what they were really doing is giving me another set of hands, another set of ears, another set of shoulders that people can lean on. And I'm blessed. I have two. I'm going to give a shout out to them. I hope they eventually see it. My physician's assistant, her name is Jessica DiLeonardo, and my nurse practitioner is Heather Solzbach. And they are just incredible human beings. Incredible. And so I think what they have become, you know, we're tied at the hip. I think when I walk into a room, one of them's coming with me. I go down the stairs to go to the infusion center, one is with me. It's a totally different experience than I thought I could have imagined. And so I do think experience was the changer. Some very incredible, bright, energetic, witty young ladies who are just marvelous and who really care about patients. I mean, they're the mother hens. They're there. And so now I think, you know, we're stronger when we're united. We're stronger when we have more numbers too. And we have more numbers now. And I think that's the way that I look at them.
I think that's great. I think we have a question online, but before we do that, I don't know.
Do we have a nurse in the room?
We do have a nurse in the room, and she recently came to work with us. Her name's Kim Parham, and she's an RN, and she's worked in lung cancer for more than a couple of decades, and not only with patients, but in helping to build patient programs similar to this. And she came to work with us about a year and a half ago, a month and a half ago. We stole her away from what she was doing, and she's from Tennessee. So I'd just like maybe, Kim, if you have a couple of comments on what Dr. Arena said and how you feel about what your sort of role was there and what he said.
Well, I think sometimes nurses can take...
You're good.
Okay. Nurses can sometimes take the time and just spend and answer questions while physicians are seeing other patients as well. And sometimes it's a little bit more accessible to reach a nurse as well. And I think it's great when there's the team and the multidisciplinary approach, because they can bring out some of the psychosocial issues as well that they are seeing. And they may know that they're having trouble now with their insurance copays or with the side effects. And they can bring that to light, and they can brainstorm in a multidisciplinary approach with the different doctors and those who are taking care of the patient.
You know, I agree. You know, I think it's a mandate now. I think it's just within this last, I'm going to say 3 or 4 months. And NYU is part of one of the hospitals, I think there's 20 or 12 or 20 in the United States, that have adopted proactively to be a part of the Medicare consortium trying to elevate the level of care. And we're mandated that each week we have to have a multidisciplinary meeting about all the patients. And so that meeting would be that of all the physicians, my NPs, PAs, my social worker, my billers, my research nurses and coordinators, my pharmacists. And what you're saying is important. For example, if I have a great medicine for a person, like an immunotherapy, for example, for a patient with lung cancer, but they can't afford to take a cab to see me because they live way in Queens and I'm in Long Island, that's not going to help them. But if we have our social workers there, and they say, by the way, we can get them a ride. We can work this out. This, to me, I would have known it because the patient's not going to tell me, hey, doc, I can't come get my medicine because I don't have a care fare right to come here. They're not going to say that to me, but they're going to say it to my social worker and to my nurse. And then we can get the ball moving and we can have something done. That's a part of supportive care.
Absolutely.
That's
huge.
Yeah, so before we jump into sort of some of the, maybe the more financial or access or, spiritual and all that, I just want to make sure we don't miss a question online while we're still in the managing symptoms.
Do you have something?
Place. Michelle has
one question. So, Dr. Arena, Gloria wants to know, are you familiar with any formal clinical trials or studies looking at cannabinoids for pain, nausea, sleep?
Ooh. Wow. To say the question out loud, because I think some might have not heard it,
yeah.
They want to know a little bit about, are there any clinical trials that I know about cannabinoids, medical marijuana, that are being used for patients with cancer? And the answer is, I believe there are a number. I'm from New York. We're not as, how can I put this nicely?
It's going to be a California thing, right?
It's a nice California thing.
I know you are.
It's a nice California thing. We're not talking about your bagels, which you can't make for a whole wall. It's a nice California thing. But we're not quite, it's sort of silly. Politics came into view, and I believe that there are 5 marijuana farms in New York, and in order to have a dispensary, you have to own the farm. I have no idea. And so it has been somewhat limited. I'm very lucky that next to my office, the NYU's ambulatory site in Lake Success, the Perlmutter Cancer Center, we have one of the dispensing units. And so we have been very, it's only been 6-7 months now. But I could tell you now what I'm seeing as far as help managing side effects is amazing. And I do think that this has to be one of the biggest things that we have to do research in formally, so that we take the myth away, all the, Timothy Leary's and all that stuff away, and let's get some facts, because what we're seeing anecdotally, I can tell you, I haven't seen before, and I've been practicing for a while. And so I do think we have a new set of drugs, which are going to be great. And Bonnie and Michelle have, and Danielle, and we've all talked to say about how we're going to try to up the ante of research in the community. But I really do think you should look at that. There is the National Cancer Institute's website. Difficult to navigate, but you can take a look and see what is in your area. But I also would call some of the medical centers that are in this area that you can look at, because I do think that this is not frivolous. This is a real drug, and it's going to be, and if it's used properly, we don't really know how to use it yet.
And I think it's important to note in California, its medicinal use has been approved for a long time. It was just approved recreationally a little bit ago. But they really are putting a science behind it between, how much THC versus the CBDs and its use in anxiety and sleep and
appetite.
appetite and pain and all of these things, and what does that look like? And we had a remote, this is kind of a little funny, so for all you South Floridians who might be watching tonight, that we're also in our remote living room in South Florida where it is not legal. It was a huge topic of conversation at the remote living room where the patients were literally like standing in protest of how do we make this happen. But this again points back to patient voice and how important that is, and really, you know, having that conversation with your doctor. What I will tell you is you are more than welcome to call us for any time and any reason you want, but not to have us illegally send you marijuana across state borders, because we have received those phone calls, and we just can't do it.
We don't have a farm.
Yeah. But it is an important topic. I think it is a really important topic.
Yeah, I agree.
Roger, you have a question?
I do. As a patient, where do you draw the line or determine what you want to burden your care team with?
There you go.
I have chronic pain, chronic fatigue. I assume that most cancer patients have the same thing. Is that something I want to go to my care team with and say, hey, how do we treat this, or just on my own?
Yeah. Why do you think that's drawing the line? You know, it could well be from the medicines you're taking. It could well be from your disease. Or it could be nothing to do with the above, but it's still an important topic. And again, we go back to the fabric of supportive care. It's not an ancillary, augmented limb that we're going to add to you. It's part of you. And so, again, I would bring it to the attention of your physician or your nurse practitioner or your PA and say, I'm so fatigued, I'm taking a nap, and I only feel that I have to take another nap. That's important. We're learning so much about different medicines. For example, immunotherapies. Immunotherapies are not chemotherapy. They're not cytotoxic drugs. I'm not really worried about a low white blood cell count. But one of the major side effects is fatigue. And so, again, I think we need to look at this. I need to bring it to attention of people. And hopefully, you know, the idea of doing research in supportive care is critical. So far, we've done it in nausea and vomiting. We've done it in pain. We've done it in bone health. But I do believe that we really have to make some strides in fatigue. That's something that's been left out of the equations thus far. But it needs to be brought up front. So please talk to them about it.
And I think this is really, really important because we kind of touched on it at the opening of the meeting about, you know, what prevents patients from having this conversation with their doctor, right? And a lot of it is, oh, I don't want to bother my doctor or the nurse or any of the care team with something that is probably just supposed to be happening because I do have lung cancer, right? And I think it's so, I've had this conversation with so many people and seen so many people get sick and more sick and more sick overnight. And they keep thinking, oh, I'm going to wait till my next appointment, which might not be for 3 months.
Yeah.
Right? And it's just, when in doubt, call, just make the call. It's so, I cannot stress that enough because I've seen it happen to patients where all of a sudden the symptoms of a potential side effect become worse than the treatment or the disease for that matter, and it can be really bad. So just call your doctor.
And you let it go too long, it multiplies and turns into other bigger issues.
I think Michelle has another online question.
I do. So it's Sarah. Joanne. It is. So she's asking, how much should the primary oncologist be involved with other treatments, i.e. like podiatrists, dermatologists? How much communicating should they be doing?
Wow. The question is, how much communication should be between different subspecialties, sub-practitioners in the care of an individual patient? And the answer is as much as you can possibly think of. You can't work in a vacuum. And I think technology might help here. Technology will actually help here. Because there's a mandate a few years ago that we had to be with electronic medical records. So most practices, almost by mandate, are in EMRs, as we call them. The only problem is that, just like everything else, like there's 20 different car companies, there's 20 different EMR systems, and they don't talk to each other. I think that is sort of getting better. One of the major companies is called Epic. It's probably got the market share. And so one of the things is try to see if your doctor is hooked up to the other people that he sends or she sends you to, because then they can read each other's notes without having to pick up a phone. It's a hassle. Is the person in? Is not? They're seeing a patient. So I think technology could be very helpful here. The other thing too is that it's important because each physician might give a different medicine, and we're learning that there's so many drug-drug interactions.
Right, conflicting.
I really worry as heck about that, I got to tell you. And so I do want to know. I don't need a thesis on what you're getting and why they think it. It'd be as simple as this is the diagnosis and this is what I'm treating. And so I do ask that. One of the simplest things I tell patients, if you're going to see someone, I know it's not in the NYU family of physicians, I will say, have the doc write down on his prescription or her prescription pad, your diagnosis, what medicines, and you give them to you. And then I'll take it from there. So this way we're not worrying that the secretary didn't fax it or didn't do this or that. So again, use the patient as their own pro-advocate. And that's what I would suggest, because I do think that drug-drug interactions are much bigger than we reckon with, much bigger.
So is it enough? So what you're suggesting is that a patient somehow track it?
I want the patient to be their own shepherd. You're the one that cares most about you. And so live it. So when you get a test, please have it sent to you. And if you're referring oncologist or your radiation therapist or your surgeon or your internist says, I don't know what's going on. Oh, really? Here you are. Have a copy. And it won't ever get lost in the mail because you know if you didn't get it. And that to me is the key here. So be your own advocate.
And is it true that one drug could actually diminish the effect of another drug?
And it doesn't have to be another cancer drug.
Right.
It could be an antibiotic. It could be a medicine that we're using for totally different things. And it's so important. I think the thing that is frightening me the most these days is the interaction that could affect the heart. There are drugs that just mess up how our medicines that we're working, whether it be immunotherapies or hormonal therapies or chemotherapies for cancers, and then all of a sudden another medicine will be given that seems totally benign. And it causes what we call QTc prolongation. The heart is like, whoa, the electrical current just went out.
Yeah.
That's what you don't want. So please, you got to have a list. If there's one thing that you should carry in your purse or your wallet, is a listing of your medications. That's totally up to date.
Yep.
That to me is the key. And every time you see your physician, you or the nurse takes the history first or update your medicines, please.
Or you end up in the ER or the hospital.
Or you take off your fentanyl patch and they find you on the floor.
Exactly. That too.
So, go ahead, Dave. Just grab your mic.
Can I ask a question about, I guess it would be fatigue? And as a Tarceva patient, that was one of the side effects that was told to me. But I've never thought until really tonight that maybe the cancer itself has a fatigue factor. That if I wasn't taking Tarceva, and without my cancer is getting worse because of that, but just the fact that I have these tumors, do they cause me fatigue separate from my targeted therapy. And how do you know that?
You don't know anything. You know that the person has fatigue. And so now, being Sherlock Holmes, you need to go into it and figure out what you can fix. Now, there's an old adage in oncology that usually when a tumor gets better, the patient feels better. Okay? So if you told me, if I'm not mistaken, your scans were looking really good, and that usually is a great sign that the onward effects of the cancer should be lessened. It doesn't mean that the effects of the therapy have to be lessened. And so we're in this paradox between therapy, its side effects, and the disease, and its other ramifications. So the answer is go straight at it. Grab the bull by the horns. Right now, it's counterintuitive, but one of the best things, and you're doing it, you have done it, the best things for fatigue, believe it or not, is exercise. So how many patients come to me and say, "Doc, I feel so terrible, I'm tired." Yes, I would like you to walk for 30 minutes every day. Didn't you just hear me? I'm tired. Yes, but again, there's this whole thing, whether it be the endorphins that get stimulated, whether it be just the muscle that gets stronger, it is a terribly important type of thing. And so, again, I think it's from both, and especially in the early stages of treatment when the cancer is usually at its worst or at its time where it's starting to, do some havoc, or when people start to relapse. It's often difficult to say which is the cause, but we still go after it.
I think that while we're just kind of talking about exercise and fatigue led to exercise, I think earlier we were talking about nausea and then maybe weight loss. What we didn't talk about a little bit was cachexia. And how can a patient tell the difference between, a potential muscle wasting versus actual weight loss?
Wow.
I know that's not on our thing.
It's a good question, though.
I didn't realize anything else was on the thing. So that's okay, too.
We've gone a little off
We're
base.
going off base.
Surprise!
But, this is a really profound question. Is weight loss the same thing as cachexia? No.
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 Right.
What is cachexia?
Anybody?
For those who might not know. Nobody knows.
It's just a total wasting. It's an old term. Again, we go back to these old physician terms. Cachexia is like the wasting of the body. It is just a breakdown. It's not just the weight, it's the muscle loss, it's the integrity of the body itself. One of the things you teach medical students is you look at the patient, and this is why I told you before, I wanted everybody to look at you, because you don't look cachectic. You look vibrant. Not fat, vibrant.
You're cute.
And one of the things that we teach a medical student is that take a look at the temples. There's no fat here, really. But when people are cachectic and they lost this weight and the muscle tone and everything, you'll see these temples called bitemporal wasting. It just comes down like this. I could see it from the end of the room if I saw a patient. At the first part of my examination. And so the old clinicians would teach this in medical school of how you assess. The assessment is the first second you see the patient. And so cachexia is much more than that. Yes, there is weight loss that happens with cachexia, but it's so much more than that. As diabetes, you lose weight in diabetes because you're pouring out volume because the sugars are too high and it makes it excrete through the kidneys. That's not weight loss. That's phony weight loss. That's your water weight loss primarily, and then the muscle is starting to get all messed up. And so my answer to you is cachexia is so much more than that. And weight loss, yes, it happens with malignancy. That's something that we ask every patient on the first encounter. Have you lost weight? And invariably, most patients do, especially with solid tumors. Not all, not all. Lung cancer patients in particular, especially in my experience, the EGFR positive patients, are not the same disease. It's not the same disease. I think the other thing is, my other pet peeve is lumping diseases together as if they were one disease, lung cancer. Lung cancer is not one disease. It's at least a half dozen diseases, minimum. And we're probably going to find it to be maybe 2-3 dozen diseases when we find different mutations. And each of them will have their own little mijigots, as we used to say in Brooklyn, all their little stuff. And so if I had to give a poster person of who was an EGFR mutated lung cancer patient, it would be a female, non-smoker, and most likely Asian, though they don't have to be Asian. But that would be the poster person. In my neck of the woods, where I live and practice, there used to be a company called Grumman. And Grumman made everything from the F-16 fighters to the lunar module that put the man on the moon. And they employed thousands of men and women. And because it was a government subsidized, they got cigarettes for free, or just about free. And so what I see as my lung cancer patient is the hardworking Jane Does and Joe Does that smoked. And they're almost invariably not mutated. That's a different disease. Totally different. Therapy is different. Prognosis is different. But still, there's so much there now. Now we realize there's many categories of that. So again, when we get to this stuff about we have to individualize. Everything is individual now. We've learned a lot.
So before I move out of this sort of space, again, I know I said that like 20 minutes ago, but really this time, does anybody else have any questions personal to you? Maybe any side effects that you're experiencing or any questions you have about side effects that you want to ask Dr. Arena that you can maybe take back to your physicians online? Anybody in the room? Nobody has any side effects at all. You're perfectly happy with your cream, Dave. You don't need anything else. You brought your box. You've got the ACT and the cream, and you're done. Nobody has any questions about that part. Okay, because what I do want to move on to, we've got about 30 minutes left, and conversation here to happen, and then some housekeeping things from ALCF, is the emotional, financial, and spiritual, because those buckets are sort of outside of the taking care of the physical, clinical sort of aspect of the disease. Is that something, like where do patients turn for that? Is that something they talk to their medical oncologist about, or their nurse, or sometimes are there palliative care specialists that kind of field all of this? What does that look like?
I think this is a profound question because at the end of the day, these are terribly important issues. And be very frank with you, again, 90+% of all oncology is an outpatient. And even before we joined NYU about 5-6 years ago, for over 30 years I've had a social worker as part of my practice. It's precisely because not because I don't care, but because there is not time in the day to do everything for you. The whole aspect of the patient is so important. And so we really have put that as part of our practice. This is how we practice medicine. And part of it is to have a social worker, and we now have two. We have 2 social workers, we have 1 dietitian, we have 1 genetic specialist, because it is such more complicated issues right now. The financial issues, patients don't want to talk to our oncologist about financial issues until it hits the proverbial fan. Doc, I can't take my medicines anymore. I don't have enough money. It's the rent or it's the medicines. I don't have it. They're not going to try to do that, but they will talk to my social worker. They will, from the get-go, I'm worried about what is the copay, what is this, and we do have lots of means. There are wonderful, wonderful pharmaceutical companies that, despite all the rancor and all the hollering, there's a lot of good pharmaceutical companies, and they do care. They have incredible programs that support patients, that help them with the copay assistance. And the only way that you know of it is that it's made available to the patient, that they're having this problem, they're having this issue, and direct them. The same thing goes with financial assistance. I think this is, we're living in a very tough time right now. I think, we were talking earlier today about healthcare, how it really needs to change, and we really need to grapple with major problems, not just dysfunctional types of things inside of our Congress. We need to all come together and talk, because it's wrong. It's wrong. We really got to help each other. And I think, you can help a lot, somewhat, and it's very meaningful. If you have someone who's truly a financial counselor, not someone is the bookkeeper and saying, how come you didn't pay your copay last week? But someone who's really helping them understand what are the avenues, and there are avenues for this. And sometimes it is a write-off, like, okay, there we go.
I have a question for you. Do you recommend an advocacy association to your patients to get those answers?
I think it has to be, the answer is yes and no. The yes part is that I am totally a believer that there should be foundations and advocacy groups that really pick up the slack. I'm a member of the 1 in 9 Breast Cancer Coalition in Long Island. I think it's more than Long Island. I think it's on the Eastern Seaboard. And there's also another wonderful foundation called, by a dear friend of mine, Dr. Dwight DeRisi. It's called Lean On Me. And Lean On Me is a really wonderful group of people. And what it is, patients trying to talk to patients. So that if a person gets, and his practice is primarily, if not exclusively, breast cancer, a new breast cancer patient can be said, listen, do you want to talk to someone who's went through this? Or who had the surgery or had the reconstruction or is getting the chemotherapy? And they will have, patients talk to them. But I think this idea of the financial is so complicated. I don't think there's, if we're all these people in the room, I don't think there's one insurance company that we have the exact same policy.
Right.
And so I do think that we need to have specialized people who can sort of traverse the seas of figuring out who's paying for what.
Well, and I think one of the things that's a challenge too is, and there's a lot of great groups out there who will help with financial assistance, but there's usually, they have to make under X amount, blah, 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 right? And they don't necessarily look at demographics, because the lower end of the spectrum in a place like here in the peninsula is going to be much higher than it is in Arkansas. So somebody here who may not, the cost of living is not factored into whatever their base salary is. So that's a challenge, right?
It's a huge challenge. And I think it's even, I think what you're bringing out is really the idea that where we live is where we get treated, huh? And where we live has its own everything. The price of housing could be different between where I live and where you live. The cost of living is totally different in different sections of this country, as is the standard of pay. It's different. And so my hope is that locally, whether it be in the practice itself, which is what my hope is, that you can get that individual type of care, which is the financial aspect of it. It is a complicated thing, something that we don't take enough time to do. Not enough time is looked at. And I think we need to do more on this. This is really uncharted waters.
So Dr. Rena, you said that at NYU and with your group and how you work, you have all of these. Do you find that to be, whether it's the social worker or somebody to help with financial assistance or, whatever, emotional assistance, anything psychosocial, do you think that's limited to academia? I mean, we work primarily with folks in the community setting, right? I mean, that's where most of our patients come from, although we ultimately, a lot, wind up getting them second opinions in the academic setting. That's where they're coming from, where maybe these services aren't provided.
I'm a hybrid. Originally, I started out as assistant chairman of medicine at Sloan Kettering, and then I went to private practice. It was 25 years. And now I'm part of NYU, but I consider myself still a community practice. And the way that we are really a very interesting type of mix. We're a community practice that is really the cancer center for NYU in the Long Island community. And so I do think, and the way the world is working right now, I can't imagine that there's going to be many truly private practices left in a few years. They're going to be hybrids or some type of mix or whatever you want to call it that is between the community and the academia. I think that could be very healthy, to be honest with you. There are things that I don't like about it, and there's so many more things that I do. And if one of them is going to be to have the resources to do these things, because back in the day, I had 6 medicines, 6 chemotherapies, adriamycin, methotrexate, 5-FU, vincristine. It was a short list. Now, I have dozens of different immunotherapies, it seems. I have different targeted medicines. And the prices and the payers and stuff, it's totally different. So you really need an infrastructure in the community. It can't come from a mythical ivory tower somewhere and it's dribbled down into the community. That would be a disaster.
Mm-hmm. There's a phenomena out here in our area where the academics are doing virtual tumor boards with the communities and kind of combining services for the benefit of the patient, because the community practices can't afford all of the people that you just named that you have working on your staff.
And here goes to the other thing too, and I think, Bonnie, I think it's a two-way street, because the physicians in the community see patients every day of the week. That's what they do. They're not out there to write papers, they're not there to give lectures, they're not there to do anything primarily. They're there to primarily see patients. And I think their experience, and we went through this, in this day of age, medical oncologists that are practicing in your neighborhoods came from very good medical centers. They came from the UCLAs and the Stanfords and the Scripps and the Memorial Sloan Ketterings and the Dana-Farbers. That's where they got trained. And they came back to their homes, the places where they want to raise their families. But they come with an amazing set of credentials and experience. And I think if those tumor boards that are combined between the community and the academia are true two-way streets, that the people that are really seeing patients for a living are empowering those that are thinking about research or thinking about basic science. Now we have an incredible mix. Now we really have a dynamic duo that can't be stopped. And so I do think that could be very healthy as long as there's respect on both ends. And I'm not certain if that's truly good. I know at NYU, I think it has been a very strong type of feeling to have this. I think this is something which I'm certain others are doing too, but it has to be this dynamics and mutual respect, because I do think there are really great levels of expertise that are in your own communities.
That's great. So I want to, does anybody have any questions? Sorry, I always forget to pause. I know. I'm on autopilot all the time. Anybody have any questions before I move on? No? So one of the last questions I wanted to ask before we close is, and we touched on it a little bit when we opened, is about research in this space, in this space of supportive care. Is there any, and does it show that patients do better, whether it's progression-free or overall survival rates, or better quality of life, benefit, any of that?
Yes to all the above. Yes to all the above. At one time, when we heard the term palliative care, erroneously, it was considered end-of-life care. Could not be farther from the truth. And study after study has shown throughout this last 20 years that the earlier that supportive care is given to the patient, the better they do. Better they do. Now, again, we have to be sincere about this. If most of the patients are going to be in the outpatient setting, and they are, it is the primary duty of the primary oncologist, either his or herself, with their nurse practitioner, with their PA, with their social worker, or with their nurses, to deliver that supportive care. Now, the real question is, do you really need to send somebody to a palliative care specialist? I don't think so. Unless there are issues that physician cannot deal with. And that can be. Pain control is the best issue. I mean, I probably call a pain consult once a week. I'm pretty good in taking care of pain. I am a pain, but I'm really good at taking care of it. And so the answer is, I do think that there has to be this true understanding that this is not something that should be an add-on. This is the fabric of how you practice medicine.
Yeah.
That's how I think of it.
Yeah.
And I think when people are shy about it, then we have trouble. Then we find patients falling through the cracks.
Yeah.
What I really do also is we have to teach better. Us doctors have to teach better. We're doing a poor job. We're doing a poor job because our poor interns and residents are being hammered. There's so much knowledge that they have to acquire within a very short period of time. And one of the first things, and it gets me crazy, a patient of mine might come into an emergency room. The first thing I will get from the call from the resident at the ER will go, "Is this a palliative care patient?" I say, "No. I want you to take care of this patient. We're going to fix this pulmonary embolism that they have. We're going to treat this patient. And if I need a pain, we'll call pain control. And if I think we have too many factors, I will call formal consult. But you have to know you have to take care of the whole patient. Don't dish it off. I hate this idea somebody else is going to take care of it. I don't want them to learn that. I want them to learn that they should be wearing this hat as their primary hat, is patient care, patient support. And if they're eager to learn about, the new medicines or the new techniques or a new way of ablating a heart arrhythmia, whatever. But they have to learn that their real job is to support patients and to get to them. And if they can't do it themselves, learn how to get the proper help.
Does everybody in the room feel like they're getting this type of care?
How do you personally define palliative care?
I personally define it as supportive care. I consider it supportive care for all the issues that Danielle brought out tonight. Whether it be pain, whether it be nausea, whether it be bony health, whether it be psychosocial health, whether it be the social types of issues, whether it be the emotional support, the spiritual support, the financial ramifications of being sick. That's supportive care. I can't do all of them, but I can do a lot of them. And I need to support my patients by, just like, I'm pretty good. I'm a pretty good internist. Was a chief resident at one time. I'm pretty good. But if a person has a complicated arrhythmia, I'm surely not going to not call a cardiology consult, because that's really, I need that level of expertise. Same thing with palliative care. There may be issues that really require this. I think, pain is probably the one that comes out most, but I think we're missing the boat on cachexia. I think we really need to see us get better, whether it be by medical marijuana or other means. I think we need to do that. I think we're falling behind terribly when it comes to the psychology and the depression that happens and the total social type of upheaval that happens with cancer. Cancer is a social disease. It affects not just the patient, but the entire family, their entire friends.
Well, and I think we hear quite often, particularly when it comes to some of the more emotional aspects of dealing with cancer, there's a tendency for some, not all, but some physicians to throw drugs like Ativan at the patient and just, sort of put them into this space. And I don't know that that's necessarily the answer or either. And that could be a whole, sort of living room on its own. I think one of the big takeaways tonight for me, and I really hope for all of you, is sort of where Dr. Arena ended this, absolutely on all of the above. And patients who have this conversation with their, some member of their clinical care team about palliative care, whether they call it palliative care or supportive care. If you're confused about what they're calling it, ask them, number one. And number two, the question that was asked is progression-free survival, overall survival, and quality of life better in patients who receive this from day one? The answer was yes. That's a huge takeaway. Taking care of the whole person, top to bottom, inside and out, is such an important part of this journey and what your treatment plan should look like. So I really, really hope that's what I heard as the sort of top line. If you take away nothing else, take that away with you, whether, again, you're in the room or online or coming back and watching this later. It's so very important. Well, that, and don't rip off your fentanyl patch. That was a pretty important takeaway too. Right?
It's a good one.
Am I right?
Absolutely.
Am I right?
I highly recommend that you do not do that.
So before we go into housekeeping, is it anybody online, comments, questions, anything?
Other than they think he's the best doctor ever.
Everybody now wants to fly up
Pretty much
to the Northeast.
And they like the New York attitude.
Yeah, well, right, because it's direct, it's to the point. Yeah, that's great. Anybody in the room?
One thing we didn't touch on is anxiety, and we don't have to go into it in a great detail, but it's also okay to talk to your physician about that, because a cancer diagnosis and anxiety kind of come the same day. And it can get you down, and it can make you tired, and it can make a whole lot of things happen. So that also can be controlled.
And I think we talk a lot here about all of the services and the things that we talked about tonight. We do provide. We're going to, like, this shameless sort of, who are we? But we do, through our navigation services, and we do help with, questions to ask your physician, second opinion referrals, but also resources to help with a lot of these things, whether it be financial, spiritual, emotional, or otherwise. So please don't hesitate to reach out to us for help and guidance in where you might need to go.
I think this last part, and you guys do a phenomenal job here. And it's not just because I'm sitting in this chair right now and had some wine. It's because you do. But I also want to maybe say something about who you get your support from or your advice from. Your hairdresser, the guy that fixes your car. I had an aunt who had, and you believe him. And you got to be selective. You got to trust people that really have the knowledge to go to that other level. I'll tell you a funny story if you have 2 seconds.
Of course.
There was an elderly gentleman that I took care of many years ago, a little Italian guy from Brooklyn. He came in with his little Italian wife. And he had one of the worst colon cancers I've ever seen. And I treated him. And he came in 3 months after we started treatment. His scans were beautiful, fantastic. And I said to him, Luigi, the scans are beautiful. And he started to cry. I said, I thought there were tears of joy. He says, no, doctor, no more oysters. What? No more oysters? What are you talking about? He says, my wife tells me if I eat 12 oysters a day, the cancer will go away. I hate oysters. And this woman was, because her hairdresser told her that was the cure for freaking cancer. And so this poor guy was suffering. I got him really better but he was suffering through his oysters. Well, his wife had the best intentions in the world. She wanted her lovely husband to be better, and she was trying her best. And I understand it. Her hairdresser, the same thing. But here's the but. You were destroying this man. You was torturing him. And so we see all this, practicing oncology, especially in the community. We have some weird things. And it's not because they're malicious, but they're just ill-advised. And so I do think that another takeaways I would take, this is an incredible foundation, incredible resource, and I would lean on it rather than go to your hairdresser.
That's what I was going to say. And
I'm not sure if that's a compliment or
that was a compliment.
Yeah,
okay, just checking.
Being raised in an Italian family, I know all about Italian superstition and karma and how you have to eat the oysters even if you don't want to eat the oysters because somebody told you to.
And she's the one making you do it too.
Don't put your shoes on the table. There's all kinds of things.
Don't do that.
Never put the shoes on the table.
That's a
Bad
great
luck.
story.
Bad luck. Italian, bad luck. Don't put shoes on a table ever.
My nonna
Especially new shoes. Put on the table.
Danny knows too.
Polenta.
Polenta's perfect.
Polenta does cure everything. That and like 80-year-old flour.
Pasta.
Yeah. That's funny. Any closing words before I go into housekeeping, other than what you just said beautifully?
I'm thrilled and honored to be here today. Again, I say to the patients that are here and their supporting cast, you're a marvel, you're amazing. For those that are listening and seeing that, hey, we live in perhaps the most promising time in medicine's history ever. Last year, in 2016, there was a new cancer drug approved every 16 days.
Yeah.
There wasn't 16 oncology drugs when I started this at Sloan Kettering.
Right.
Every 16 days, there was a new drug. That's unheard of. And so our knowledge of the science of everything is coming into fruit right now. And I think with a little bit of hope and lots of guidance and lots of support, I think we have a future and you have hope. And if all these wonderful people were here, their stories, just think about that. Just think about that for a second. And that's what I like to leave you with.
That's awesome and so true.
And I think it's such a valid point about the drugs. I mean, I know, and somebody can correct me if I'm wrong, but it's since just this year, so in the last 7 months, in lung cancer, the NCCN guidelines have changed 6 or 7 times, right? So just this year. So things are happening, and it is a hopeful time. And a huge thank you to you, Dr. Arena, for coming and talking to us about all of this. I'm going to do a little bit of housekeeping before we do the big round of applause and close. One of the things I'm really excited about that's happening in September is most of you are familiar with the Lung Cancer Alliance, and we are partnering with them to do a living room during their National Advocacy Summit at the end of September. So we're so excited to go out there and do a remote living room from Washington, D.C. alongside the Lung Cancer Alliance. So that's coming up
with another foundation.
Yeah, we're working on marketing material, which Michelle and I will get out to you as soon as we have all the details and the information. The San Francisco 5K is coming up, people. It's also at the end of September. I don't see anybody from events here to give specifics, so I'm going to wing it maybe Andrea's going to go get him. Going to go get somebody. Although I'd love to know the specifics of all of it. I don't.
All of what?
Like, what's the actual date for the San Francisco 5K, the Spartanburg, the Hollywood, the
24th?
Everybody. Oh, here's Katie.
24th.
Hi.
Right.
Good evening, everybody.
Here comes the
Katie,
boss.
if you could just for folks online and in the room, Philly, Spartanburg, San Francisco 5K, Hollywood 5K, Gala, Lily's Lights.
You got it.
Thanks.
And we have Gala coming up. Jen made sure I put that one in. But
perfect.
Thanks for joining, everybody. Welcome. So I'm on the events team. For most of you, you already know that. We put on 5 different types of events. Those are, we have a 5K series, which runs across the country. And then we also have a golf and gala event, which are signature events. We have an endurance program. That's where you can run and a Hillsburg Marathon, a 5K, a half marathon. Those tend to be the longer duration of runs. And then we have a grassroots series where you come to us with an idea and we support you. That could be anything from a benefit concert to a car show. But we're really excited because we have Hollywood, Florida's 5K coming up in just about a month's time. And so we'll be out there putting that one on. And then for those of you in the room, we do put on a San Francisco 5K. And we really hope that everybody here in the room, because you're local, you come out and participate in that. It's a super fun one. And I can't share all of the exciting stuff that's happening, but we will be incorporating some fun themes this year. Actually, the theme, I think, already went out. Okay, it did. So we are going to be doing the theme of, why is it escaping me?
Love.
Summer of love. We're doing the Summer of Love. And we will have a band out there this year. It's a survivor performing with his band. So it's going to be awesome, amazing. Come out, participate. We have a top team right here, actually.
We got passed.
Yeah. And, you know,
they are killing it.
Dave got passed?
We got passed. Is anyone from Team Edwina here?
No.
Oh, yeah.
Oh.
3 cheers to Team Edwina.
Okay.
They blew through 10,000.
Okay.
There's no
Cheers to them.
So we have a little competition going on. But again, if you're local, come out. It doesn't mean you have to run or even walk. You can hang out, listen to music. There's food trucks. It's a lot of fun. So the date for San Francisco is,
24th.
I'm really bad with dates, you guys.
24th.
September 24th.
Yeah.
And Katie, just if there's anybody young enough in this room that doesn't know what the Summer of Love was in the 1960s, it was quite a time. It was quite a time.
Pretty sure that's when I was conceived.
And they're actually celebrating. Yeah, it's my love child.
There you go.
1969, right here.
That's a way to close the living room.
That's how you do it. No more said.
Done. It worked. So you know, that's why we did this, because it's all over San Francisco celebrating the Summer of Love. So we kind of tagged on to what's going on there.
It's going to be awesome.
Yeah.
Let's come check it out.
Thanks, Katie. And then, of course, I want to say a huge thank you to all of our supporters and sponsors whom, without their support, we would absolutely not be able to provide this to you locally in the room, let alone to the masses over YouTube, those of you who are signing in live, and or those thousands of you who will come back and watch post-live. So with much gratitude, we want to thank Tesaro, Astellas, Bristol-Myers Squibb, Celgene, Genentech, Lilly, Merck, Novartis, and the Yahoo Employee Foundation for all of their support of our efforts here for you, the patients, which you all know we are. Is it good? Is it good for the patient?
It's good for,
then
it's good for the patient.
Then we're going to figure it out. A huge thank you to Peninsula Television. Those of you online who maybe have not been online before. I think most of the people in the room have been here before. Penn TV is a local cable television station that comes out each and every month. They set up all of their equipment. They're here way before you guys get here, and they're here long after you leave. So a huge, huge thank you to them. For those of you who are local, Channel 26, a little plug for Penn TV, but they will be replaying this throughout the month. So each month they replay the new living room station on cable TV, and we've actually been places where people that we don't know have come up to us and said, "Hey, you're the cancer ladies. I watch you on TV."
The cancer ladies on TV.
Yeah. So,
and for those older patients in the room, like me, if you're up in the middle of the night, pop on 26 and you can watch this all over again. Yeah.
This was me last night because I thought I was drinking my sleepy time tea and it was actually Earl Grey.
Oh, no.
It was horrible.
No.
That's a whole other story, though. So huge thank you to Peninsula Television and then the Office Bar and Grill for once again supplying all the food. For those of you local, if you haven't checked out the Office Bar and Grill, please go do.
Tell them thank you.
And tell them thank you. So a huge thank you to Dr. Arena for coming out and talking to all of us. We would Thank you. We would absolutely love to have you come back out again, and we'll have a different topic and talk about something different, but I think it was fantastic.
My pleasure.
I just have to tell you, I think your passion and commitment behind who you are and what you do for patients is amazing, and I can't thank you
My
enough
pleasure.
for coming and doing it.
Thank you so much.
Of course. And then last but absolutely not least, because you're always first, is the patients. All of you in the room and those of you online watching, those of you who will come back and watch later, you are why we do what we do. Thank you for sharing your stories and your time with us here every month. It means the absolute world. Everybody have a wonderful night, and we will see you next month.
Thank you.
We're still rolling. Are we still rolling?
No.
Okay.
The lights went off.